Hi, this is Julie Lubinsky. I'm the Associate Director of Digital for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this month's live chat with Nurse Linda. She's a leader and provider of rehabilitation nursing for over 40 years. And she, within our brand new online community, Reeve Connect, she writes about and answers your SCI-related healthcare questions in our health and wellness discussion. I encourage you all to check it out. And now I'm going to turn it over to Linda. Hi, Linda.
Hi, Julie. And thank you, everybody, for tuning in today. Spring has finally sprung. Boy, did we have a caustic winter, but it seems like things are on the turnaround. It seems like things are getting on the mend. So I just got back from Washington, D.C., where I was honored by the Association of Rehabilitation Nurses to be sent to advocate for people with spinal cord injury in Washington, D.C. So this was like a big excitement for me. Interestingly enough, I was at the 2020 the NIH 2020 SCI conference for disrupting research 1 month ago, which was in D.C., and there was such a horrible winter storm you couldn't even see across the street. It was so bad, and the weather was just terrible, and you couldn't see anything. You didn't know where you were going. It was pouring down rain. Schools and businesses were closed because this horrible storm was approaching. Now I go back exactly 1 month later, and flowers are in bloom. People are out along the Potomac enjoying themselves, and it just was such a contrast of what 1 month can do. So I think we're headed now into some better weather. So hopefully that's benefiting everyone across the country. So I did want to talk about that 2020 conference, though. It was an interesting meeting. I did a blog on it if you happen to read it. It's a little different than my blogs because I don't usually report events like this, but it was a very interesting conference because what was so different about it was sponsored by the NIH, which is not that unusual, but the way it was arranged was that they had researchers that are working on treatments and cures for spinal cord injury, basic science, physician researchers, clinical trials people. They had nurses. There were some therapists there. But the big plus was that they invited people from the community to come, and there was such an overwhelming turnout that they had to open up extra rooms to accommodate everybody who had come to this conference. So it was kind of a who's who in the spinal cord injury community, be it if you're on the scientific side or if you were on the community side. There were a lot of key power players there. I think I can call them power players. And separately me. But anyway, there I was. And so they had done a presentation where they had the researchers talking about different avenues of research that people were working in, like basic science, in the laboratory, doing experiments to find out if they're safe, then to be translated into clinical research, which is the human side. So they gave updates on where different segments of those areas were advancing and improving, and leaps that they had made. There's been so many leaps in research right now. And so that was a very informative presentation, but what I really enjoyed and really could relate to was that personal side, because they had speakers that represented the community. And there were a variety of people. The people that had their own separate address were people who had been very active and very vocal. But there were people from the community, just like anybody that wanted to come, could come and give their opinion, and people did, and it was wonderful. I know in working on both sides and also being a caregiver for a person with a spinal cord injury, I know that that sometimes those two positions don't really link up together. In working with some researchers that work in laboratories and universities that that they're sometimes not connected with hospitals, or even if they work in an academic medical center but they're in a laboratory, they don't often see people with a condition that they're working towards finding better outcome for. So there were scientists there that had worked for a long time. They had certainly had developed relationships with people in the community because the community people had forged those relationships and the scientists were amenable to it. But there were also a lot of laboratory assistant type of people. So people who were either in school, younger people that were looking to go into research as a career, and they were either interested in spinal cord injury or they had a position in somebody's lab where they were just starting to learn about the whole process. Sometimes when you meet young people like that, they have never met anyone with a spinal cord injury. So this was a real opportunity because it gives them that kind of fire in the belly to really understand what's going on. When you can take an issue and connect it to a human person and know that you're going to help this person and help other people that you haven't met that are in the same situation, it really makes a difference. I know when I'm working and I've met different people, sometimes I get up in the morning and I think, I'm working for John today, or I'm working for somebody who's written in the blog today. And it's not that you're not working for everybody, but you kind of conjure up that interaction that you've had with that person. For me, it might be a meeting one-on-one. It might be somebody I've taken care of who's had a spinal cord injury, or it might be somebody who's written into the blog. But I kind of think about that one person on that day, and it just makes, it's like I have to keep going and I have to keep working because, this is going to make a difference in this person's life. So I could see that in the young people who were there at the meeting, and that was very exciting. Of course, meeting people from the community and, finding people, they know me from the blog or from different things that I've done, but I've never really met them. So that was very exciting. It was just a wonderful opportunity. I think that there were strides made on both sides of the table, and I wish that it could go even further. I wish that we could, get something accomplished right now. One of the things that they did mention is something that they do know is in the mice model. They do know now how to make the nerves grow from above a spinal cord injury or below a spinal cord injury, how to make those nerves grow through the glial scar. So when the spinal cord gets injured, even if it's bumped on the outside of the spinal cord, what happens is a hole forms in the center of the spinal cord. So you would think if you got a bump on the side of your spinal cord that's where your injury is, but not really. It's the injury forms in the center of the spinal cord. So it looks almost like a donut if you look at it from a side view. If you look at it like you're slicing a loaf of bread, you'll see a hole in there, and then there's a little scar that forms around the hole that's made in the spinal cord, and that's called the glial scar. And for a long time, scientists could not get nerves to grow through that glial scar. It was hard, and they couldn't get anything to go through it, but they've been able to do that in the mice model, and so that was big news. And so, now they need to translate it. They know that there are different elements that will make that happen, and they need to now figure out how to make that happen in a human body so that those connections that can be made. Some of the things that we discovered, one by a variety of scientists, but one in working with Christopher Reeve in his recovery project and doing brain mapping with movement. So he had gotten a lot of functional return through activity. And one of the things that we found is through the functional MRI. So you all know an MRI, when an image is taken, there's a large, powerful magnet that creates image of the inside of your body. And the functional part is that MRI is done while a movement is being conducted. So with Christopher Reeve, when he was making a movement, it would be light up in one part of his brain, but after a spinal cord injury, it would be another part of the brain that would take over that movement. So where that movement was supposed to be happening in the brain wasn't happening, but another part of the brain had learned to take over that activity. So it's all very complicated, but it's all starting to come together. And different elements are really being pieced together. This is really wonderful news. But one of the main thing that came out of the researcher part of this conference was that activity. And if you read the blogs, I'm all into activity. Activity is nothing new in neurological injury. People who had polio years ago, in the big round of polio that came out in the 30s and 40s, would go to centers, and their bodies would be moved by people, just constantly moved and moved. They did a lot of aquatic therapy, because when you're in the water, the buoyancy of the water helps elevate your limbs, and your limbs float if you're very calm in the water. And now if you add resistance for exercise, that makes it a little more difficult to work against the water if you're resisting it. But if you're floating, you can kind of support your limbs and appendages, and so if there's an ability to move, you're removing some of the gravity factor that's keeping you from moving. So some people learn to move in the water, and then when they build up their strength, then they can make those movements on dry land and become functional movements. And so activity is always the key, and of the keynote speaker, that was the main thing, was incorporating activity. Unfortunately, I think that a lot of people that go to rehabilitation, they receive activity in their therapy session, but then when they leave the therapy session, the activity is concluded. It's like, well, I'm having therapy, so someone's moving my limbs or my joints, someone's helping me move my body. But then when they get out of therapy, or when therapy has concluded, people stop doing those kind of movements. It's very important that you keep going with that. You can move your own limbs if you're able to. If you're unable to, if you have somebody else go through the range of motion with every single joint in your body, and then think about that movement when it's happening. So we know that there's a lot of connections that are made. If somebody's moving your hand, and you're really not watching, you're really not paying attention, it's just an activity that you're going through, we know that those connections are not made as quickly, as effectively, as efficiently as if you're watching that and thinking about, someone's moving my index finger. My index finger is moving up, it's moving down. And if you think about those things in your head, then some of those connections are made a little bit more. There's been a couple of people, and it's happened more than with this one situation, but I've had a couple of people that have enjoyed driving cars. They've either done it professionally or they just enjoy driving cars. And so sometimes in their imagination, while they're either, just getting up in the morning after their spinal cord injury, they'll start thinking about, driving a car, and they'll close their eyes and they start imagining driving the car and putting their foot on the gas pedal and going down a street. And usually it involves driving very fast, I realize, but they'll think about driving the car and the images in their head and the feelings in their body. And I know a couple of people who've gotten some toe movement just randomly as they start imagining and conceptualizing what it was like to move and drive a car. So there's a lot of power with the mind. With this brain remapping, we're learning a lot more. So engage physically, engage in your mind, and, we'll see how that starts. But keep up with that activity. So today we're going to talk a little bit about spinal cord injury and brain injury. A lot of people don't think about them together, but it happens about with 40% of the people who have spinal cord injury also have some sort of brain injury. Oftentimes the brain injury is overlooked, and it's for a variety of reasons. Sometimes when you're brought into the emergency room, you're either unconscious and people can't really assess your brain function. In higher level thinking, they can see if you're having brain function with breathing and maybe pain control, but if you're unconscious, you can't really talk and respond. So sometimes brain injury is not really that recognized early on. Sometimes when people get into And then after that, you might be having surgery, so you're anesthetized. You might be on a ventilator, so you can't really talk to people. It's a very trying time for individuals and their families. But after a while, people tend to go to a medical unit or to the rehabilitation facility, and that's really the time where more of the brain injury is picked up. Sometimes the brain injury is not that severe. I mean, you can readily see a severe brain injury right away if somebody's answering inappropriately, not able to organize their thoughts, different kinds of activities and responses with the brain working. But sometimes people are able to talk to people in the rehabilitation setting, and they have what they call cocktail conversation. Somebody comes in, how are you doing? Oh, I'm okay, fine. It's almost an automatic response. You know, we say that to each other every day. Somebody will say to you, how are you doing today? And our automatic response is okay, because we know that they're not really interested in our aches and pains. It's just kind of an opening. So people don't often recognize that there's a problem with the brain until maybe you even get home and suddenly the family members will recognize that, well, gee, maybe you aren't handling money well, or maybe you can't do calculations as well. Maybe they'll notice that you've had such a huge personality change. Sometimes these things are just written off of, well, they've had this big trauma, they've had a spinal cord injury, so of course they're depressed, and of course, you know, they're not really engaged in conversation because they're having such a rough time, which can certainly happen, but oftentimes it's because there's also a head injury when the spinal cord injury happens. So if you think about when there's a spinal cord injury from trauma, that's such a force that happens in your body that, you know, the whole body is reacting. Sometimes people have loss of blood, which might result from some brain injury. Sometimes it's just the force of the movement. So, for example, if you're in a car and you're in an accident, your body gets thrown around and maybe you have a lower level spinal cord injury. People don't automatically think, well, gee, that was such a big force that caused that spinal cord injury. Maybe the person bumped their head or their brain got shaken some way around in the skull because of the force of movement. The skull moves slower than the brain will move faster and bounce up against the skull. So you might not have any external injuries, so people don't automatically think there might be something amiss there. Now, if you have spinal cord injury from a medical problem, it really depends on the medical problem if you might also have a brain injury at the same time. So sometimes people, I'll use the example of multiple sclerosis, is a development of plaques in the spinal cord. We know that multiple sclerosis, the myelin, which is the protective layer around the nerves, dissolves for some unknown reason, becomes ineffectual. And so messages don't get transmitted along the course of the nerve because the myelin that holds the electric impulse is no longer there, so it just kind of splays out into your body. Well, if you have multiple sclerosis and you have plaques in your spinal cord, you could also have plaques in your brain or vice versa. Sometimes with multiple sclerosis, the plaques are first noted in the brain. Sometimes they're first noted in the spinal cord. So it's a good idea to have a check to see if you have any kind of brain injury. Your physician can do some simple testing in the clinic. Your family might notice some changes in your behavior, your mood, that doesn't seem like a depression or some other kind of illness going on. They might notice some higher level thinking, you maybe can't concentrate as well in reading. And after a huge trauma like spinal cord injury, people can't concentrate so well in reading. But after a while, things sort of normalize and you can kind of get back into your old activities. So be sure and have yourself checked. Your health professional can do a quick check. If they notice that there is some kind of disturbance in what's going on, or even if the family or you say, I just can't seem to figure out how to handle money. That seems to be one of the higher level activities that tend to be a problem. So you can ask for testing to be done by a neuropsychometric psychologist. Now that's a mouthful, but it's a psychologist who does nothing but testing. They've been trained to give these tests to assess how your brain's working, and they can isolate exactly what part of your brain is having a problem. So it's not just like your whole brain. Parts of your brain will be perfectly fine, but they can isolate where the issues are occurring, and then therapy can be created and established to create a therapy situation where you will be successful. So if you're having problems with, say, remembering short-term memory, so maybe you don't remember what time your therapy schedule is, your therapist can give you a schedule, or they can give you exercises. If you can't recall what the exercises were prescribed, then they could give you a schedule of you need to do these exercises, maybe pictures of someone doing the exercises, maybe pictures of you doing the exercises so you can see what you can do next. It's always kind of handy to have pictures of what's going on because we all learn and see by many different ways. There's a lot of research that's gone on about some people are visual learners and some people are auditory learners and some people learn better by feeling things. And they've kind of divided up into 5 different senses of the way that people learn. We all know that's a bunch of bunk now. So if you're an auditory learner, sorry, your whole brain works together. If you've been told you're a visual learner, your whole brain is working together. I think everybody learns better when they see something. Some people seem to click into things better when they see and hear something. We all learn better when we actually go through the steps and physically make the movements of doing whatever activity. So those are just some things to think about. But SCI and brain injury is not uncommon. For the higher level injuries, people will sometimes think about brain trauma because if your body has been injured up higher, closer to the neck, you can figure that the neck is a very small structure. Your head is a relatively large, heavy structure, and the little bitty neck has to hold up a lot of the brain and whole head structure. So if you have a higher level injury, people will sometimes more often look for the brain injury as well. So hopefully that's not a problem, but if you think that you're having some kind of issue with memory or concentration or being able to function as you were before your injury, don't just write it off to your medication. Don't just write it off to depression. Be sure and check with your physician. They can do a simple test in the clinic and find out right away. So let's go to some of these questions and see what people are thinking about today. So any suggestions for a bowel program? Well, I always love to talk about bowel programs, especially when you want to get back on track after being constipated or having diarrhea. Limitations on the laxatives. So here he says, I'm sure you get my point. Yep, I think I do. So sometimes after your bowel's been disturbed, say you've had the flu or something's happened and you've had some severe diarrhea, always check with your healthcare professional before you go off and do anything, especially if you're going to ingest something, because we don't know about you in particular. But what a lot of people will say, if your bowel's been swept out with diarrhea, a lot of the flora, the natural bacteria that's in your bowel, bacteria in there. And so a lot of that flora has been wiped out. So some people will suggest a course of probiotics just for a month, just for that one bottle of probiotics. You don't have to buy the most expensive ones. Any one of them work just as well. That helps get that flora back in your bowel. That's what keeps you from continuing to have the diarrhea. So that's one thing, but check first, because we don't know. I don't know what other medications you're on or what your health history is. So check about that. That certainly helps. probiotics have had a lot of bad press lately, but I'm not talking about probiotics forever, just a one-course month. It puts the flora back in, and then you're ready to go. Certainly eating yogurt has probiotics are in yogurt. There's different bacterial cultures in there. So when you eat the yogurt, that certainly helps with diarrhea as well. Now, when you're being constipated, so you're not having bowel movements or your bowel movements are very hard, you might want to add some fiber either through your diet, or you can take things like Metamucil or Citrasil. Those things, those kind of bulk laxatives help provide fiber, help give the stool some bulk, help your bowel be able to force those along. Drinking water certainly helps with constipation. Now, you have to be careful with that if you have heart condition, if you have some edema problems, or if you're on a bladder management program because you don't want to over-distend your bladder. I'm not talking about drinking gallons and gallons of water, but just trying to add a little extra fluid into your daily routine, which can be a swallow or two. A swallow or two in between your catheterizations. Maybe you can build up to a swallow or two of water every hour. That way you don't overload the system so quickly because your body still has to process all of that fluid. What do you do if you need to get back on track with your bowel program? Most people do their bowel program with a suppository every other day followed by digital stimulation. If you find you're having constipation, perhaps you would like to do the bowel program every day until you get results and start having a normal stool. If it continues to be hard, or if you continue to have problems with a constipated stool, you'll need to add more fiber or water to your routine. Now, a constipated stool is a hard stool. It's difficult to pass. It's kind of more almost like rock-like in formation. That does not mean a neurogenic bowel, which is a problem that people have after spinal cord injury, where your bowel's not working as swiftly to move the stool along. So constipation and neurogenic bowel are two different situations that require different treatments. So that's why you do the bowel program, because of the neurogenic bowel. But it doesn't mean you can't get constipated also while you have a neurogenic bowel. Some people will say, and I hear healthcare professional people say this as well, and I read about it in journal articles where they'll say people with spinal cord injury are constipated. No, they're not constipated. They have a neurogenic bowel. It's a neurological problem versus a stool moisture problem, which is constipation. So get back to your usual routine. You can do it every day. Once you start having more routine, normal bowel movements, then you can back off of the everyday routine if you've been constipated. If you've had diarrhea, you might want to hold your bowel program for a day until your bowel settles down. You might want to hold the laxatives for a day, but you don't want to go too awfully long because you don't want to get constipated after the diarrhea, which often happens to people if they have a spinal cord injury or not. So be sure and check with your physician if you're adding anything. Check to make sure it's not interacting with anything else or it's not causing another problem of a health problem that we don't know about that you have. But those are what people usually do. So I hope that's some help there. Continuing with bowel programs, do you have recommendations for a bowel program with spinal cord injury and anal fissure? Is the enema better than manual evacuation? Okay, so here is one of those situations, just like I was talking about a healthcare problem that, doesn't always leap to mind because not everybody who has spinal cord injury has an anal fissure. Sometimes anal fissures happen because of the bowel program. Sometimes people get them because they've been sitting a long time. So it's not unusual, especially for people who are truck drivers who sit in their rig for a long time. They often have hemorrhoids and anal fissures because they're holding their stool because they got to make their run, so they don't want to stop in toilet. That's money off the table every time they're taking a break. So they don't want to stop and go to the toilet and have a bowel movement. So they just hold it and keep going, and it becomes constipated. That leads to hemorrhoids. And when hemorrhoids get big enough, or sometimes when the bowel gets overstretched, you'll get a fissure in the tissue, which is kind of like, it's an opening in the bowel. It's kind of like a cut, but it's not from the source of a cut. It's from overstretching, and the tissue just separates. I guess that's a better way of putting this. The tissue will separate. So that leaves an open sore in your rectum. And so if stool gets in there, of course, it can get infected. So now if you have one of those, what is better to do? And it all depends on the depth of the anal fissure, how big it is, and, basically what your situation is. So some people have them up higher. Some people have them down lower, closer to the rectal opening. Some people have an anal fissure around actually the anus, so the sphincter where the bowel opens to the outside of the body. So is an enema better or manual evacuation? So you'll have to check again here with your healthcare professional. If you are doing an enema, the complication can be that you now have wet that stool and it's become more mushy, softer. It can, as it goes out of your body, it can enter into that fissure quite a bit more easily because it's moist. It's more pliable, I guess, is what it's, or you can have some of the stool get into the mixture of the enema water, and so that makes it smaller and easier to get into the fistula. Some people will continue to do manual evacuation, but they need to have use a lot of lubricant, which everybody should not. Don't go stingy on the lubricant, because that's what's going to keep things in your rectum moist, and it will not cause any tension between your glove finger and the bowel wall. The bowel wall doesn't really anticipate that there's going to be anything up against it. So it's moist. If you put something dry up against it, that's going to cause a little tear, which can make a little fissure in there. So always use a lot of lubricant to make sure that everything stays well moistened, and it's easier to stretch the sphincters if things are well lubricated. So a lot of less complications there. So which is better? So you really need to check with your healthcare professional about this, because it all depends on where that fissure is and how deep it is and what's going on with that fissure. So follow the instructions of your healthcare professional. I can tell you about each, which I've done, but I can't tell you for you directly unless I would know more about your healthcare issues and that anal fissure. What you really want to be careful about is to keep that clean so that stool doesn't get in there and then that gets infected, and then that infection can spread throughout your body. So we talk a lot about sepsis on the blog and on the webinars. And sepsis is something, is an infection of the entire body. It's if you have an infection, like maybe you get a pneumonia, or you get a cut, or a pressure sore, or an anal fissure, it gets infected. And what will happen is that can spread throughout the body. You can get infection of your major organs, and it's very serious. It's life-threatening. So if you get the symptoms of sepsis, which is a high fever, if you get confused, if you lose consciousness, if you're feeling in any way that you suddenly become very, very ill, you want to call 911 about a sepsis incident right away. But so I will leave that up to the healthcare professional. Enemas are good. Sometimes they're quicker. is less trauma. Manual evacuation if you need to keep your finger well lubricated, and be very gentle. I notice this a lot. I've been a rehab nurse for a lot of years, and when people do their bowel program, they put their finger in there and they are as aggressive as they can because they think that is what's really going to help that stool come out. If you have spasticity, that's going to close your sphincter down. The more aggressive you are, the tighter that sphincter is going to be, and the longer your bowel program is going to take. Digital stimulation should be a very gentle kind of movement because you want to relax the sphincter and not cause it to tighten up. Now, if you have a lower level injury, you're going to do more of a manual evacuation. And if you don't have spasticity, you can be a little more aggressive, but you don't want to be so aggressive that you create hemorrhoids or fistulas or fissures. So just be very, very tranquil. Your bowel does not anticipate that there's going to be any probing of it in any way, shape, or form. So be very gentle because that's where the trouble comes, is when people get way too aggressive with that. Now, here's a situation. I can't get the VA to schedule my baclofen pump. I'm in painful leg spasms. So this is the problem with all health care, is sometimes there are just more people than there are slots. So at the VA, there is an ombudsman, or they might call it a patient representative. So if the government is very serious about these waits in the VA, and so there's going to be a person at your VA facility, either a patient representative. They're not going to call it the complaint department, but that's basically what you're looking for, is a complaint department of somebody who can intercede and act on your behalf. Now, you can call and keep trying to make appointments. But you want to be what they call a friendly pest. So you're calling, but you don't want to be extremely aggressive or harsh with the scheduler. They can only schedule appointments. So you can keep calling. You can call the ombudsman, who is basically the person in the hospital who takes complaints. You can call the Consumer Relations Department at your local VA. There will be some department, if you ask the operator, I'm having a problem with the VA, who can I talk to? They should be able to send you to the office because the VA takes this very seriously. Sometimes if the VA cannot schedule you in a certain amount of time, they will authorize you to go into the private sector to have treatments done. And there's a method for doing that within the VA, so check into that as well to see if you can get it done elsewhere, if you can't get it done when you need to get that baclofen pump scheduled. There is a procedure for the baclofen pump. You just don't go in and get a baclofen pump. You have to go in and do what they call a trial. So they put a little tube, and it's little tiny, like a size of a needle, into your back, and then they put some baclofen into your spinal cord, and they see how you respond to the trial. They call it a baclofen trial, because you don't want to go through the whole surgery and have this put into your body not knowing if it's going to work. So they go ahead and they do this trial, and it's really hard for people if it's successful, if the trial's successful. It's really hard because they get relief when the drug is being injected into the spine, and then they have to wait and have the pump actually implanted at a later date. So after they've had that relief, you don't want to stop having that, but that's the way it works. And usually they try to put the pumps in, if it's a successful trial, they'll try to put the pumps in right away because they don't want people to have to go back to that situation they were in before. So be sure and talk to somebody, because if you feel like you're being detained in any way, be sure and talk to somebody at the VA that can help you move ahead, kind of intercede on your behalf. Now, it could be that the waiting line is so long to get the baclofen pump that it could just be it might take them a couple of months before they're able to schedule you, and maybe that's their routine. But if it's going to be a very long time, or if the waiting period is, if there's many people ahead of you, then they will sometimes schedule people into the private sector so they can get care sooner. So there's multiple ways to work within the VA system to get that taken care of for you. So I hope that works out for you quickly. How do you prevent bladder infections as a female wearing an indwelling catheter for 42 years? And if you can't attend, will there be a transcript? Yes, there is a transcript. So this is all transcribed, or you can listen to it. These are recorded, and so you can listen later just by going on to the Christopher and Dana Reeve website. So you will be able to hear this again later. So how do you prevent bladder infections? So this is a problem because when you have an indwelling catheter, you have a conduit that's going right into your bladder. That's the catheter tube. And so bacteria can just go right up in there. So there are some things that people do because they've never been educated about it. And I see it in healthcare. I see it in the hospitals where I go. I go to a variety of places. I think nursing schools are getting a little more in tune to some of these rules, but they've been lax for a while. So you never want the catheter bag to be higher than your bladder. Okay, that's the first thing. So when people get into bed, they put their leg up. Maybe somebody's moving you and your leg gets put up higher, or your leg gets up on pillows but your leg bag's still on there. There is a valve to keep urine from backflowing, but that doesn't always work well. Or sometimes it's hard for the urine to come out if the bag is higher. The catheter closed system works on gravity. So the bag has to be lower than your bladder. If you have a night bag, it has to be lower than your bladder. Sometimes people will put, if somebody has a night bag on and they put people into bed and they'll throw the bag up on the bed, well, it's higher than your bladder. You've got to keep it down low. So it should never just be tossed around. Some of the other things that can happen is kinking in the catheter, or in some ways that it gets clogged, that the urine cannot flow out, and so it backs up in the bladder where it has time to let those bacteria multiply in there. That's like the very first thing. Hygiene is another thing to keep clean. That sounds like kind of a ridiculous thing. There's some schools of thought where people want to clean the catheter up by the meatus where it goes in to the body, and they will sometimes pull the catheter down a little bit because there gets to be some body secretions on there, which is just normal body secretions, and so they want to get those body secretions off of there, and they get pretty aggressive with that, and then the catheter gets kind of pushed back up in there into your bladder a little bit further, which carries any bacteria from that cleaning process back up into your bladder, or any soap residue that can be an irritant that can also set off bladder infections. So those are a couple of things. Another thing is that with women, you're sitting in the chair, the catheter is there, and there's not a lot of air circulating around that catheter. So your legs are pinched together. You're sitting on top of the area where the catheter's entering. So even if you don't have a catheter, people who sit a lot, who have their legs pinched together, if you don't even have a spinal cord injury, you're probably going to get an infection. So you want to be sure and air yourself out as often as you can. If you can separate your legs a little bit, sometimes just putting a little washcloth in between your legs, not up close, not right up to the catheter, but kind of just a little bit close to it, say like an inch away, that will create a little air packet. So if you fold up a washcloth and just put it in between your thighs, up closer but not right up to the catheter. That creates a little air pocket to let a little air circulate in there. That's very helpful. There are a lot of things that people take thinking that they will prevent a bladder infection. If you look on the website, on a website, you can type in foods to avoid for bladder infection and foods to gravitate towards. That sometimes helps. If you, for some people, that will sometimes help, but that's not the end of that's not a cure. Drinking, since you have an indwelling catheter in, you can drink freely. So drink water. Stay away from sodas, either diet or sugary drinks. A lot of sports drinks, a lot of these electrolyte replacements. There's a lot of fluids that are advertised is going to be really healthy for you. They have a lot of sugar in them. They have a lot of caffeine in them. Water is your best bet. So you can be drinking a lot. Now, that doesn't mean to go out today and start drinking a little bottle of water every hour, but take sips of water throughout the hour. Keep yourself well hydrated. It's better, you can certainly drink at a meal. You can certainly drink whenever you're thirsty. You've got a catheter in, so what goes in is going to come out. But you can increase your drinking, but slowly from what your usual routine is. As I mentioned before, don't start in with, well, I'm going to drink a glass of water every hour. That's going to overload your system. You've got to build up slowly. Drinking like at lunchtime and then not again until dinner is okay, but what really is going to keep your kidneys working and flushing is to drink a little bit. You can certainly have your mealtime beverage, but then drink a little bit in between your meals, so that you're always drinking constantly. And by that I mean, like, say every 15 minutes or so, have a couple of swallows. You don't need any more than that. You can have more than that, but a couple of swallows every hour or so just will kind of get you started and not overload your system. It also is going to help your skin to stay healthier. Once you get your fluids built up in your body, your skin gets well hydrated as well, which is also a bonus for skin, as well as for women who like to keep their complexions with that youthful glow. So there's a lot of benefits to that. What else can we say? Either using new equipment each time, or if you have to reuse equipment, look at your cleaning technique to make sure that your equipment is being properly cleaned. Look at the timing of changing your catheter to make sure that that's staying clean. So if you've had an indwelling catheter for 42 years, I would say you're already successful. So maybe there's something that's changed in your metabolism that has perhaps altered the output of your urine. Just as we get older, our bodies change, and so the reactions that our bodies have don't work as well as they did when we were younger. So things just change naturally within our bodies. So be sure and drink. Another thing that you can do is add activity. If you're not moving your legs around much, if you move your legs, your feet, your knees, your hips, if you turn your body from side to side, that's going to shake that urine in your body. If your urine's moved around in your bladder, it doesn't have time for those bacteria to collect. Rolling at night, doing your push-ups during the day. If you're not able to push yourself up and you have a recline on your wheelchair, putting yourself back and forth a few times, like every 10 minutes or so, will help keep that bladder shaken up as well. So be sure and do your push-ups. So that should keep you pretty clear. If you continue to have problems, you can talk to your physician about some kind of maintenance program for your bladder. You can request a urological consult. If you haven't had urodynamic testing, you will be sure to want to have that done because, as I said, your body changes as you age. So sometimes with having an indwelling catheter in for that amount of time, your bladder might have shrunk down to be very small, and so that without having that stretching and then relaxing as your bladder fills and as your bladder empties, that could be an issue that's causing some trouble too. So be sure and get some urodynamic testing to make sure that everything's okay in the system. And it's good to have it, and if it is, that's great. You've got a baseline so that if you have trouble in the future, you'll know where you were at this one point in time. So that's a very helpful thing to do as well. Okay, is it true that a gel donut on the bottom makes a decubitus worse? It depends on what kind of gel bottom. If it's one of those gels that it says a gel donut, so if there's a hole cut out, that tends to concentrate blood and fluids in the area. It tends to constrict. However, sometimes there will be cushions that just have like a little divot cut out, and but the gel is surrounding the whole surface of where you're sitting. So that makes a huge difference. So this lady has a first layer, and wound care is not necessary, but the nurse told me this. So whenever I hear the word donut, I think, oh no, get rid of it. Donuts tend to constrict the blood from flowing to the area exactly where you want it to go, because what happens is the wound will settle down in the donut hole, and then that donut will constrict the area around so you have less blood flow there. Now, that being said, many people who have wounds will have maybe a gel cushion, but as I said, the gel is completely over the whole surface of where you're sitting, so it's not that constriction like a donut. So whenever you have that hole there could be a constriction. Sometimes people will just have, as I said, just like a little divot taken out so that there isn't that constrictive pressure, but there's not really any pressure on the wound itself, which is what you want to avoid. So you might want to talk with somebody about getting a new cushion, which would probably be to your benefit. Some of the cushions that disperse the pressure evenly would be much better. If you have a pressure injury, the important point is for healing it is to stay off of it. So every time you sit on any kind of cushion or any kind of bed surface, when you have, if you're laying on a bed surface, when you have a pressure injury, you're applying more pressure. That's just the way it is. So check to make sure you've got the correct piece of equipment. You might want to talk. You might want to go to the wound care center now before the wound gets any worse, because if you're sitting on it, it will get worse. So that's the important thing, is to stay off of it. If you go to a wound care center, they're going to prescribe a cushion for you that's going to be pressure dispersing. They're going to check to make sure if your gel foam cushion is dispersing, or if it's a donut ring, then it's constricting, even though it's gel. So you want to get the right piece of equipment. They can do mapping of where you're sitting to see where the pressure areas are, and then they can recommend a cushion that will disperse the pressure away from those pressure areas. They can also recommend a bed surface for you as well. If the wound is just on one part of your body, then don't lay on that part of your body when you're in bed, and try not to sit on it, which I know is just like impossible for people who are working, going to school, living life. You know, how can I get up? Well, if your wound gets so bad that you end up having to have surgery, if it's not healing, even if it's just staying the same, then it's not healing. So be sure, unless it's improving, it's getting worse. So be sure it's never a bad idea if you have a wound to have it checked out by a wound care specialist, because they can get the right treatment for you. Sometimes people say, well, I'm staying in bed, I'm staying off the wound, I'm still turning, but not on the side where the wound is, but I have to get up and brush my teeth. Well, the minute they sit up in that wheelchair for 5 minutes, they've just destroyed all that time they've spent off the wound. So it's really quite a conundrum, and you want to get that wound cleared up as quickly as possible. So I certainly would recommend going to the wound care center, even if you have a red spot that's not healing. Wounds start from the inside of the body. When you see the red spot, there's much more damage inside the body than what you see on the surface. So they're sneaky little tricky things that can turn just bad overnight. So be sure and go to the wound care center, and then you'll have experts that are looking particularly at your situation and at your particular needs. Here's the next question. Is it a risk for a C5 quad in having a chemically induced heart stress test at a cardio conversion to correct AFib heartbeat? And now the doctor wants me to do a stress test. So if your doctor is prescribing that, then I would certainly ask him, is there a risk? Well, people who have spinal cord injury sometimes, quite often, develop cardiac problems, and it sounds like you're maybe in that situation. Maybe the cardiac issue is from something altogether different, but I'll just assume it's from a consequence of the spinal cord injury. So people who have paralysis can't do the treadmill, the active stress test, so they have the chemically induced. So they give you some drugs, they stress your heart. Many people have these stress tests, and they do not even realize that they've even had it. They know the drug's been injected, but they don't feel any different. Some people will have, if they have problems, or just sometimes they'll just have difficulty, or they'll feel pain, or they'll feel the heartbeat faster because they've had the drug, which still doesn't mean that they have a problem. It's just that they have noticed that they're having a response to the drug. So what I think would be the important thing for you to ask your physician or the people who will be caring for you during the stress test is at C5 to think about autonomic dysreflexia, which can result from the stressed heart in the stress test. And be sure and take your pocket card so that they know how to treat autonomic dysreflexia. They will be monitoring your heart and your blood pressure during the test, so they should be able to detect any AD that's coming on, maybe even before you get any symptoms of AD. But that is the thing that I think I would be sure and check with them if they are adept in detecting and treating autonomic dysreflexia. The Christopher and Dana Reeve Foundation has an autonomic dysreflexia wallet card that you can take with you to your stress test. You can give to your physician. Be sure and ask him, do you think it's okay for me to do this stress test? We don't know what all's going on in your body. You've already had some heart problems, so you want to be sure and ask your doctor if he thinks you're a good candidate. Ask the cardiologist who will be doing the test if you're a good candidate, and be sure and ask the question about the autonomic dysreflexia. Other things, will they be able to turn you during the test so you can get your pressure releases? You probably won't be doing a bowel program during the test, but will they catheterize you at your catheterization time? Make sure that all of your care needs are being met during the test, but in particular, the autonomic dysreflexia is going to be the issue for anybody who has a cervical or thoracic spinal cord injury. Even if you've never had autonomic dysreflexia before, it could be triggered by the stress test. So that's something to be sure and note. Oh, here's a very typical situation that can be very difficult to deal with. This person has a brother who's been incapacitated for 2 years now with a spinal cord injury, But now he's becoming depressed. Is this common? Is there anything that can be done? Certainly there's things that can be done, and yes, this is very common. Sometimes people who have a spinal cord injury might go through a depression at the time of the injury. Sometimes people don't really have a big depression at the time of the injury because they are so interested in fighting the injury. They are so interested in getting better. They're going to do everything that's prescribed to them, and they follow the book, and they just do everything to try to improve their situation. And then in a couple of years, if they haven't shown any improvement by that time, they become depressed and they kind of crash. It's usually in that after a year to 2-year mark. This is extremely common, because what has happened is the person has put, and this is not right or wrong, this is just the way anybody would be. They've put all their intensity into doing everything they need to do to make themselves well, and then time goes by and they don't feel like they've reached the point where they want to be in their wellness. But what they haven't done is really adjust to the new normal. And that's a difficult thing to accept. So what they've really been doing is, I've been fighting this, I'm going to beat this. And that's a great motivator to have, because it's going to keep you very healthy, because you're doing everything just right. But then after a certain amount of time, people think, wait a minute, this is really difficult, and I'm really tired of this, and I'm tired of fighting this. And, anybody would be like that in that situation. So be sure and talk to your healthcare professional, because there are treatments. You would want to have your brother talk to somebody that can maybe help them through this depression. There are medications. Sometimes people don't want to take medications, especially for mental health issues. But, if you have cancer, you take medication if you want to, treat the cancer. If you have heart disease, you take medication to treat the heart disease. If you have depression, there's medication that can help you with that depression. And so you want to be able to treat it so they can move forward. But try to get also in with that somebody that they can talk to kind of help with these issues, to work through all of this, that they can be sure and reach some kind of acceptance of the issue, because that's going to help them continue to move forward. As I started with the program this morning or this afternoon, I mentioned all the research that's going on and the huge advanced strides that they are taking. But when you're in a chair, one day is one day too many. So there's a lot of things that's going on. There's a lot of reasons to be hopeful, but it's still going to be taking some time. And when you're living in the situation, it's a lot. The time becomes relative. It's a lot longer time. So be sure and have him talk to somebody and get some treatment for his depression. That's going to be keenly important. And it takes time to treat depression. It's not an overnight cure. So having that support of a person that they can talk to and that has some experience helping people work through tough times is going to be critical. I can see it's at the top of the hour, and so it's time for me to say goodbye, but I am on the community tonight. So if you have a chance to dial in, if your question didn't get answered, on the community there is a little inbox if you'd like to email me personally and privately, or you can just ask the question on the community. If you have a question, somebody else is at home and they're thinking the same question, but maybe they're just a little too shy to write in. So if you have a question, be sure and write it in. If you want to keep it personal, that's fine as well. So I thank you for coming today, and I hope you'll come back again next month. Bye.
And ladies and gentlemen, that does conclude today's conference. Thank you very much for joining us. You may now disconnect.